Welcome to the Cardio Plan event today. We're going to be talking about new hypertension guidelines. We had this conversation in December and decided we wanted to continue it this month. There was a lot of interest in the new guidelines. Hi everyone and welcome. I am Rebecca Wilson at HealthInsight and this is Catherine Luke. Thanks for joining us today for the Change Agents Learning and Action Network webinar. We're glad that you could join us today. It's just now the bottom of the hour, which is our official start time. So we'll probably have some people join us, but in respect out of all your time, we'll go ahead and get started with our agenda today. So first, this is the conversation today, New Year, New Hypertension Guidelines. We talked about this in December if you were able to join us, but there was so much interest in the topic and in the highlights of a couple of clinics that we had on to talk about their home blood pressure monitoring program that we wanted to talk about it again today. And then we also really want to hear from you. So keep that in the back of your mind. We want to know your questions. We want to know what you're doing with the new guidelines. We want to know if you've implemented any home blood pressure monitoring programs. So we'll get to that in a little bit. We've got Dr. Barry Stultz from the University of Utah Medical Center to talk about guidelines, and then a little bit later on in the second half of the hour, most likely, we'll have Carrie and Jamie, both from clinics in Utah, who have implemented successful home blood pressure monitoring programs. So everybody's here and available to give you some information and answer questions today. But before we get into the content, I just want to make sure that you all are familiar with this platform. I don't know how many of you have used this Zoom webinar platform before, but if you hover along the bottom of your screen, a toolbar should pop up like the one that you see at the bottom here in black. And here you'll find some different functions. You've got participants, so you can see who else is on the call with us today. And you can raise your hand if you want to get our attention. There's also a chat button. If you hit that, a window will open up, and you can see on the bottom in blue, you can change whether you want to send that message to everyone or to specific people. But right now, we would encourage you to use the chat. You can see Edie in our New Mexico office has asked you to put in your name and the name of your practice you're with. That's always helpful for us to know who's calling in and where you're all located. So take a minute and do that. While I tell you about HealthInsight, if you're not familiar, we're the Quality Innovation Network, Quality Improvement Organization. We're in 4 states, Oregon, Nevada, Utah, and New Mexico, and I'm sure all of you are calling in from those areas. And we really work on the CMS quality strategy to eliminate disparities, strengthen infrastructure and data systems, enable innovation, and foster learning organizations, much like this one here today. So thank you for joining us, and thank you for putting things in the chat. I see Nevada represented. I'm sure we have lots of others out there. I see your names on the screen. So thanks, that helps our presenters too to know who they're talking to. So first, we're going to take some time to go through the new hypertension guidelines that were released in November. Dr. Barry Stultz from the University of Utah Medical Center is a professor of clinical medicine and internal medicine, and really has specialized in the management of resistant hypertension. So thank you, Dr. Stultz. I will turn the time over to you and let you go through what's new here. And if you put yourself on mute, or Rebecca, if you can unmute him.
Hear me then. So the new guidelines from the American College of Cardiology and American Heart Association that came out in November were commissioned by the National Heart, Lung, and Blood Institute way back in 2014. And as we noted last time in December, those guidelines were reviewed and then accepted by the 11 different societies that you see listed here. But things have changed a little bit in that these same guidelines, at least the blood pressure thresholds and targets, were rejected by the American Academy of Family Practice in mid-December, and yesterday by the American College of Physicians, which is one of the internal medicine organizations. So we do have some controversy. As we've noted, these guidelines are very comprehensive, covering diagnosis, treatment, prevention, and plan of care in 47 subsections, a very long document, 169 online pages that provide 106 evidence-based graded recommendations that are based on randomized trials and meta-analyses of those randomized trials, but importantly also on observational studies and in some cases on expert opinion. You can get this document for free at the website that's listed here on the slide. Next slide. So each one of these guidelines is graded according to its strength as class 1 through class 4, that is strong, moderate, weak, no benefit or harm. And each recommendation is graded by its level of evidence. From level A, more than one high-quality randomized trial supporting that evidence, all the way down to level C, expert opinion based on clinical experience. Next slide. So let's talk about some of the key recommendations, including a new blood pressure classification scheme and the rationale for that. The recommendation that out-of-office blood pressure is necessary to accurately diagnose hypertension, new target blood pressure and threshold blood pressure levels, hypertension therapy that is guided not only according to the level of blood pressure, but now also according to the level of 10-year cardiovascular risk, the fact that initial low-dose 2-drug therapy rather than 1-drug therapy is favored for most, although not all patients, that diuretics other than hydrochlorothiazide are now recommended, indapamide and chlorthalidone, and the recommendation to adjust therapy using home blood pressure monitoring. Next slide. Let's look at each one of these. So this is the new classification scheme. As compared to JNC7 in 2003, normal blood pressure is still defined as less than 120/80. But you can see the new ACC/AHA guidelines now define an elevated pressure as 120/129 over less than 80. And the key recommendation is that they now define hypertension as a blood pressure 130/80 or higher, including stage 1 hypertension, 130/139/80 to 89, and stage 2 hypertension, 140/90 or higher. And as you can see, this is a big change from 2003. Next slide. So why do they have a new classification of blood pressure? Several reasons. First, we have known for years that there is a log linear progressive increase in cardiovascular disease risk that begins at a systolic blood pressure of just 115, such that every 2-millimeter increase in systolic blood pressure thereafter increases your risk of stroke by 10% and your risk of myocardial infarction death by 7%. In addition, if you compare to a normal blood pressure below 120/80, if you compare this, quote, elevated blood pressure of 120/129, the studies show that it increases risk of cardiovascular events by 10 to 50%, while this new stage 1 hypertension with a blood pressure of 130/139 increases cardiovascular risk 50 to 100%. And these two blood pressure levels account for 25% of the United States population. In addition, we now know from a recent study in 2017 that 63% of all cardiovascular disease events in the United States actually occur in persons with blood pressure less than 140/90. And as we'll see on the next two slides, randomized meta-analyses of randomized clinical trials do suggest substantial benefit at lower blood pressure levels. Next slide. So the first of these meta-analyses, 123 randomized trials with more than 600,000 patients, they considered baseline systolic blood pressure and the initiation of hypertension therapy. And what they found is whether your baseline blood pressure was 160 or higher, or 150 to 159, 140 to 149, 130 to 139, or even if your baseline blood pressure was less than 130, you still reduce cardiovascular disease events by about 20 to 30%. And that occurs whether or not you have baseline coronary heart disease or stroke or other comorbidities. Next slide. A second meta-analysis of 34 randomized trials with 138,000 patients instead considered final achieved systolic blood pressure on therapy. And whether your final achieved systolic blood pressure was 140 to 149 compared to 150 or higher, or whether it was 130 to 139 compared to 140 or higher, or whether it was below 130 compared to 130 or higher, at each level you get about that same 20 to 30 to even 30% reduction in cardiovascular events. And the absolute risk reduction is quite substantial, with numbers needed to treat over 5 years to prevent one event ranging from 19 to 45. So these studies suggest that as achieved systolic blood pressure moves from about 158 to 122, lower achieved blood pressure is better. Next slide. Well, this new classification scheme indeed increases hypertension prevalence, and it magnifies the public health epidemic of hypertension. Whereas the JNC7 2003 criteria, 32% of American adults, or 72 million persons, were hypertensive. By the new criteria, 46% of adults are hypertensive. That is 103 million persons. And you can see that the prevalence of hypertension in African Americans and Caucasians is substantially higher than in Hispanics and Asians. And if we're fortunate enough, or as I increasingly look at it, unfortunate enough to live to be over 85, more than 95% of us will be defined as hypertensive. But very importantly, as we'll see, new or intensified drug therapy is only going to be recommended for about 12 million persons in the United States. Next slide. Well, the new guidelines appropriately focus that accurate manual or automated office blood pressure measurement is essential. But the purpose of office blood pressure measurement is to screen for hypertension, not diagnose hypertension. Diagnosis of hypertension requires out-of-office blood pressure measurement for most patients. And if we're going to intensify the level of blood pressure control, it is essential that we have accurate blood pressure measurement both in the office and on home blood pressure monitoring here. The guideline, at least in my opinion, doesn't make a specific recommendation to use what is termed AOBP, or Automated Office Blood Pressure Measurement, which is performed on patients in isolation to reduce white coat effect. But the guideline does contain two statements that are supportive of this approach. Automated oscillometric devices provide an opportunity to obtain repeated measurements without a provider present, thereby minimizing the potential for a white coat effect. And there is growing evidence base supporting the use of automated office blood pressure measurements performed in isolation. Next slide. Well, the guideline emphasizes that out-of-office blood pressure measurement, preferably with 24-hour ambulatory blood pressure monitoring, or if that's not available, with home blood pressure measurement, is necessary not only to diagnose hypertension accurately, but it's also recommended for treatment of hypertension on an ongoing basis. Now, in untreated patients, out-of-office blood pressure measurement is necessary to detect the 15 to 40% of patients who actually have white coat hypertension. That is, their blood pressures in the office are high, but their blood pressures out of the office are persistently normal. In addition, the guideline recommends that we consider using out-of-office blood pressure measurement to detect what is termed masked hypertension. That is, the patient's blood pressure in the office is in the high normal range, but blood pressure out of the office is persistently high, and the patients are at risk of cardiovascular events. Now, similarly, in treated patients, the guideline recommends home blood pressure monitoring to detect white coat effect, where the blood pressure in the office is higher than out of the office, but also in patients at high cardiovascular risk to detect masked hypertension, where the blood pressure looks pretty good in the office, but it's actually persistently high out of the office. And in addition, they recommend regular home blood pressure monitoring to adjust the intensity of any hypertensive therapy, as the studies show clearly that effective home blood pressure monitoring with adjustment of medication lowers systolic blood pressure by 5 to 6 millimeters of mercury, and it improves hypertension control rates up to 30%. But if we're going to use home blood pressure, it is essential that we train patients and retrain patients to measure the blood pressure accurately, because they generally do not. Next slide. So this recommendation from the American College of Cardiology and the American Heart Association mirrors the guideline 2 years ago from the United States Preventive Services Task Force that said ambulatory blood pressure monitoring is recommended to confirm high blood pressure before the diagnosis of hypertension, except in cases for which immediate initiation of therapy is necessary. Good quality evidence suggests that confirmation of hypertension using home blood pressure monitoring may be acceptable, but more research is needed on the best home blood pressure monitoring protocols to follow up elevated office blood pressure measurements, and this receives a level A recommendation. Next slide. Well, this is an algorithm from the American College of Cardiology, American Heart Association guideline that instructs us how they favor using out-of-office blood pressure measurement in untreated patients. And as you can see on the left, when the office pressures are high, after 3 months of lifestyle modification, then you need out-of-office blood pressure measurement to confirm the diagnosis of hypertension or to make the diagnosis of white coat hypertension. And similarly, in patients with that, quote, elevated blood pressure of 120 to 129/80 on the right, if those patients are at high cardiovascular risk, we should consider out-of-office blood pressure measurement to detect masked hypertension, where the pressures are actually higher out of the office than in the office. Next slide. And very similarly, this slide shows their algorithm to use out-of-office blood pressure in treated patients, both to detect white coat effect and to detect masked uncontrolled hypertension. And I'll let you take a look at that algorithm on your own in more detail. Next slide. So these are the guidelines recommended blood pressure thresholds to initiate treatment with pharmacologic therapy and the blood pressure goals to be achieved. And what you can see is that the blood pressure treatment thresholds have been lowered to 130/80 and higher for patients with clinical cardiovascular disease, for a patient whose 10-year cardiovascular risk calculates to 10% or higher using the ACC-AHA pooled cohort equation, which is available online. For patients age 65 and over, it is also a threshold of treatment of 130 or higher, provided that you are ambulatory and community dwelling. Also, that threshold of 130/80 for patients with diabetes, chronic kidney disease, coronary disease, heart failure, peripheral arterial disease, or in patients who've had a prior lacunar stroke. However, for patients with a 10-year cardiovascular disease risk that is less than 10%, the threshold for treatment remains 140/90 or higher, And that same threshold is used for patients with a prior ischemic stroke because of a lack of data in those ischemic stroke patients. And note that the recommended blood pressure treatment goal for all of these groups is below 130/80. Next slide. Well, this guideline recommends that we calculate 10-year cardiovascular risk using the ACC-AHA pooled cohort equations. Those are available at the website that you see at the bottom of this slide. But we only need to use that in primary prevention patients who are under age 65, who don't have cardiovascular disease, chronic kidney disease, or diabetes. And the reason for that is that 10-year cardiovascular risk is already 10% or higher in 90% of patients who are age 65 and over, in 100% of patients who are 75 and over, and essentially in all patients who have cardiovascular disease, chronic kidney disease, or diabetes. Next slide. Well, to summarize then, presuming that we have an accurate assessment of blood pressure, both in the office and out of the office, if a patient has an elevated pressure, 120 to 129 over less than 80, all they get is lifestyle therapy and follow-up. Patients with stage 1 hypertension, where the blood pressure is 130 to 139 over 80 to 89, if their 10-year cardiovascular risk calculates less than 10%, and this is almost 70% of patients with stage 1 levels of blood pressure, those patients also receive lifestyle therapy alone, no drug therapy. But the stage 1 patients, 130 to 139 over 80 to 89, who have clinical cardiovascular disease, or they have a 10-year cardiovascular risk that calculates to 10% or higher, or diabetes or chronic kidney disease, or age 65 and over, again, if they are community dwelling and ambulatory, or patients who have stage 2 hypertension, patients with blood pressures 140/90 or higher, these are the patients who are treated with both lifestyle therapy and pharmacologic therapy, with follow-up every month until their blood pressure is controlled below 130/80. Next slide. Well, with respect to pharmacologic therapy, there are some changes that this guideline recommends. If your blood pressure is 130 to 139, stage 1 hypertension, and your 10-year cardiovascular risk is 10% or higher, or you have vascular disease or diabetes or chronic kidney disease, they recommend initial one-drug therapy. And in African Americans, because diuretics and calcium channel blockers are more effective to lower blood pressure and prevent cardiovascular events than ACE inhibitors or angiotensin receptor blockers, they recommend diuretics or calcium blockers. In patients who are not African American, one can choose from diuretics, calcium blockers, ACEs, or ARBs otherwise. Note that beta blockers are recommended only if patients have a compelling indication of either ischemic heart disease or heart failure, because beta blockers do not reduce stroke as effectively as the other drug classes. Now, on the right of the slide, you see that if the blood pressure is 150/90 or higher, that instead of initial one-drug therapy, initial low-dose two-drug therapy is recommended. And for most patients with a blood pressure 140 to 149, initial low-dose two-drug therapy instead of one-drug therapy can also be considered. And the best choices for combination therapy are an ACE or an ARB combined with a calcium channel blocker, particularly in patients at high cardiovascular risk or who have gout, while in other patients it's very reasonable to choose an ACE or an ARB combined with a thiazide diuretic. Again, if patients are very elderly or they have a history of hypotension or drug intolerance, then we should be very cautious and probably still use initial one-drug therapy. Next slide. There are several rationales to recommend initial low-dose two-drug therapy for most patients rather than one-drug therapy. First, we know that 75% of hypertension patients need 2 drugs at least to get their blood pressure below 140/90, let alone below 130/80. Second, it is more effective. We know that that initial low-dose 2-drug therapy provides 26 to 39% greater blood pressure lowering than 1-drug therapy in randomized trials. We know from randomized trials that initial low-dose 2-drug therapy provides 20% greater hypertension control at 3 to 12 months. And at least in observational studies, initial low-dose 2-drug therapy compared to 1-drug therapy reduces cardiovascular disease events. And because side effects are directly proportional to dose, low-dose 2-drug therapy has fewer side effects and thereby improves adherence to drugs by 10 to 15% in those randomized controlled trials. Because you get greater initial blood pressure reduction requiring fewer drug titrations and fewer visits, initial low-dose 2-drug therapy is also cheaper than starting with a single drug, and many of the single pill combinations will result in fewer copays. Next slide. The guideline also recommends that we use longer-acting thiazide diuretics, meaning indapamide or chlorthalidone, in preference to hydrochlorothiazide. And this is because systematic reviews and meta-analyses of randomized clinical trials have shown that the longer-acting indapamide and chlorthalidone, 24 to 72-hour half-lives instead of 10 to 15-hour half-life as hydrochlorothiazide, at equivalent doses reduce blood pressure 5 to 6 millimeters of mercury more than does hydrochlorothiazide. And go ahead and give another click here. These same studies show that indapamide and chlorthalidone in the randomized trials reduce coronary heart disease and total mortality to a greater extent than hydrochlorothiazide. In addition, indapamide has less effect on glucose and potassium and sodium than either hydrochlorothiazide or chlorthalidone. And note that the cost of indapamide and hydrochlorothiazide is relatively inexpensive, chlorthalidone a little bit more expensive. The only real advantage of hydrochlorothiazide is it comes in many fixed-dose combination pills, which indapamide and chlorthalidone do not. Another click here. So, indapamide and chlorthalidone are better both to decrease blood pressure and coronary heart disease than hydrochlorothiazide, but hydrochlorothiazide has an important advantage that it's more available in those fixed-dose combinations. Next. So, how do we choose the best diuretic in hypertension therapy? The guidelines suggest that if the glomerular filtration rate is 30 mLs per minute or higher, if your major concern is efficacy to lower blood pressure and cardiovascular disease prevention, the best choices are indapamide and chlorthalidone. But if patients are at lower cardiovascular risk and the convenience of a fixed-dose combination is important, then hydrochlorothiazide remains a very reasonable choice. Next click. For patients who have GFRs below 30 mLs per minute, bad kidney function, or they have had hyponatremia due to thiazide diuretics in the past, then the choice is a loop diuretic. And the best loop diuretic is the long-acting torsemide that can be given once a day, titrated to a 3 to 4 pound weight loss, but with careful monitoring of potassium and creatinine. Note that the short-acting furosemide and bumetanide have to be given twice a day for hypertension control, very impractical. There is some recent data from small randomized trials that chlorthalidone at higher doses might actually be effective in patients with GFRs below 30. Next slide. So, unfortunately, the guidelines do not agree one with the other. There are 3 major guidelines that came out in 2017. The ACC-AHA guideline, the guideline from Hypertension Canada, and the guideline from the American College of Physicians and the American Academy of Family Practice. As we've said, the ACC-AHA guideline suggests that for patients at low or moderate cardiovascular risk, defined as less than 10% 10-year risk, the threshold for treatment is 140/90 and a target blood pressure less than 130/80. But for patients at higher cardiovascular risk with a greater than 10% 10-year risk, the threshold for drug treatment is 130/80 and the target blood pressure is less than 130/80. But look at the Canadian guidelines. They favor for low cardiovascular risk patients, and they define that as patients who have no other cardiovascular risk factors, that the threshold for treatment is 160/100 and the target below 140/90. If you have one or more cardiovascular risk factors, 140/90 is the threshold of treatment with a target below 140/90. If you have diabetes, the thresholds and targets are 130/80. And if you meet the criteria from the SPRINT hypertension study, and these are all patients at high cardiovascular risk, they suggest that the treatment threshold is 130/80 and you treat below 120/80. In contrast, the ACCP-AAFP 2017 guideline is more conservative. For patients age 60 and over, they recommend a threshold for treatment of just 150/90 and a target just below 140/90. On the other hand, in higher cardiovascular risk patients, which they define as a prior stroke or TIA, existing cardiovascular disease, fairly severe reductions in kidney dysfunction, kidney function, diabetes, or metabolic syndrome, they go to 140/90 or less than 140/90. So it appears that you can do about whatever you want and actually find a guideline that will support you. Next slide. The American Diabetes Association is a little different. They suggest that for most patients with diabetes, the threshold for treatment is 140/90 and the target below 140/90. But they suggest for selected patients with diabetes who are at higher cardiovascular risk, if you can do it easily, that you treat below 130/80 or even below 120/80. Again, different guidelines, different recommendations. Next slide. Can we do better? Yeah, I think we can do better. I think we need team-based care to improve hypertension control. As primary care clinicians like myself, we need to provide new roles for existing staff, or if we can afford it, add new staff, particularly clinical pharmacists. It is essential that we identify the patients in our practices who have uncontrolled hypertension. We need a registry, an electronic medical registration registry of patients with uncontrolled hypertension so that we can call them back to get them in control. Another click. We need to improve the accuracy of blood pressure measurement both in the office and in our patients who are doing home blood pressure monitoring. We favor automated office blood pressure, AOBP, performed on patients in isolation. Next click. We need to decrease our therapeutic inertia, and we need to consider using initial doses of 2 drugs rather than 1 drug, low doses of 2 drugs rather than 1 drug, and we need to get our patients back every 2 to 4 weeks until those patients are controlled. And we need to measure our performance in the clinic, both at the clinic level and the clinician level, to see how well we're doing. And the final, another click. Improving treatment adherence is very, very difficult. We don't have great ways to do it. We just don't know how. But things that can be used are following up patients by phone within a week or 2 of starting medications or increasing medications or changing medications, having available free walk-in blood pressure checks, and intensifying our education about hypertension and how to do home blood pressure monitoring. Last slide. what do we do with all these changing definitions of hypertension and the new guidelines and the fact that the guidelines don't agree? This is a reasonable statement that came out this month. Accordingly, there never will be only one way to diagnose and treat hypertension. To uniformly lower the blood pressure of all hypertensive patients below 130/80 has to be considered absurd, regardless of the ACC/AHA guidelines. However, equally absurd would it be to maintain blood pressure levels below 150/90 in all patients above age 60, as the ACP/AAFP guidelines are telling us. And what that means is we need to individualize our treatment goals according to cardiovascular risk, according to patient preference, according to comorbidities and how many medications patients are already on. And that's, I think, my last slide.
Yes, thank you so much. Lots of great information in there. And if you have kept one eye on the chat during that, you noticed some different questions that were posed in there that we hope that you'll all think about and are interested in your feedback. We'd love your reaction on some of these new guidelines. So you either have the ability to take yourself off mute, which again, if you just hover your mouse along the bottom of your screen, that toolbar should pop up, and on the left-hand side, you'll see the mute, unmute function. If you're on the computer, obviously if you're on the phone, you know how to work that one. So you are more than welcome to speak up or chat in something into the chat box. You know, what do these new guidelines mean for your setting, and how do have clinicians in your area reacted? If you are a clinician, what do you think about it? I'd love some dialogue around this. So I'll pause for a minute. And I particularly, Dr. Stoltz, really liked this slide that you had here about, you know, what different things and ideas that we can do. I think that gives people some good places to start and good things to think about. What does it mean for you? How are you going to change what you're doing? Are you making changes yet, or waiting for the dust to settle still?
Well, it's a good point. And if you look at the lower left corner of the slide there, you see that Kaiser Permanente implemented all of these measures, and they increased their hypertension control rate from just 44% in 2001 to 90% in 2013, which is the highest published control rate in the medical literature. It works.
May I ask a question?
Please.
This is Elise over at St. Mark's Family Medicine. I'm really interested in how you mentioned that we need hypertension registries, but right now, you know, we have, you know, our EMRs and we have Excel spreadsheets. And as you know, the two don't interface. How do you best recommend keeping track of these different categories of patients and trying to measure the success with your interventions?
Well, what I can tell you is in the university setting, we spent an enormous amount of time about 1.5 years ago establishing within our EMR a registry. And our registry will now track the best way to measure blood pressure. And so if a patient has had a 24-hour ambulatory monitor, which is the gold standard, that's what will be picked up as control or not control. If the patient instead has had home blood pressure monitoring, which we try to have done very accurately, the registry will pick up whether the blood pressure is controlled at home or not. If they haven't had that, we do AOBP performed on patients in isolation when their blood pressures are elevated, and when an attended blood pressure is elevated. It'll pick that up. And then if they've only had a high blood pressure done manually or automatically in attended fashion, it'll pick that up. But it took us a lot of work to get that registry established. Now, I know HealthInsight is trying to work with clinics in the community to help them, and the health department is part of this, to help them set up registries in their EMRs.
That's correct. Yeah, absolutely. And you know, Elise, Excel is sometimes what we have to go to because not every EMR has the capability to do this registry function. Some of them do, however, so to explore that is a good idea. And like I said, there are, you know, add-ons you can purchase. I know money is always tight for primary care, but learning to do a basic Excel registry is not a bad thing. I mean, basically we're putting together that list of patients and then the things we need to run them through and track them and call them back. So how, I mean, you guys are doing are you doing an Excel registry right now?
No, I haven't started one yet. We're just starting our program, but I'm having a lot of heartburn trying to get the baseline because I don't know whether to include patients who do not have a diagnosis of hypertension, but yet they're hypertensive in the office, and there's so many diagnoses to include because of the ICD-10 coding. I mean, you can have diabetes with hypertension with heart failure and blah, 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 and it goes on and on. It's just not one code.
It is complicated, and what we had to do with ours is we had to eliminate our tracking of blood pressures from the emergency department, from blood pressures from surgery, and so we only track blood pressures from the primary care clinics where we know we have instituted our improved blood pressure accuracy measurement programs.
Okay. And did you include people with and without the diagnosis of hypertension?
Yes. Yes.
Okay.
Because we know from a number of the studies now that unidentified hypertension patients are not uncommon in major systems.
Okay. And then when you individualized your plan, did you do a little combination of both, you know, the different recommendation guidelines, or do you feel a preference?
Right now, we are still on kind of the standard recommendation. So we define uncontrolled hypertension according to how it was measured. So if it is an attended blood pressure measurement, the definition is 140/90 or higher at this time. If we do AOBP, the threshold done with the patient in isolation to reduce white coat effect, the threshold is 135/85 or higher. If you do home blood pressure monitoring and it's done accurately, or at least we think it's done accurately, the threshold for hypertension is again 135/85. If you do 24-hour monitoring and you look at the average 24-hour pressure, then the threshold for hypertension is 130/80. If you were going to do the new ACC/AHA guideline and follow that, you would decrease all of those numbers by 5 millimeters of mercury.
Okay, thank you.
And Elise, we've got a new improvement, and it basically steps you through, you know, some of the measures to choose, and then it registries. And if you'll get with me, this is Catherine Luke. I found a really good resource for creating registry. It's a video that I really like, and I'm happy to sit down and we'll get this figured out. And we'll bring your providers in because they have an idea of what they think is important to track. But if we can get something up and started for them to tear apart and look at and add and decide what they want to do and what's practical, what we can do, I would be happy to help you with that.
Oh, I would completely take you up on that. It would be great.
And we're here in Utah, and the website that I was just showing you that hopefully you saw on the screen, this resource, are available through the Utah Million Hearts Coalition. Anyone is welcome to access that. And Rebecca Bally, maybe you could put that in the chat if you haven't already. I can't see the chat at the moment, but if you could put that in the chat, and then we'll also, since we are 4 states represented here today, Utah, Oregon, Nevada, and New Mexico, we can put the contact information in the chat for the HealthInsight representative in each of the states, so that if you need help with your EHR and registries and some of this, we would be more than happy to come help you with that.
So that question, Elise, kind of brings us to one of our topics that we touched on last time, which was electronic health records and these new guidelines, and how are we going to, are they going to make changes? And that's a really good question. I don't know, has anyone seen any, I mean, I'm sure it's lower on the priority list, but any of our office managers or people with access to your electronic health record, have you heard anything from them about, you know, putting these thresholds down, lowering them to 130/80, to change your alerts and your indicators within that record?
No responses in chat as well.
Okay, so yes,
It is certainly a very controversial topic. As you can see, not everybody is buying in to these new guidelines.
okay, so that's probably a ways out then if we see anything about that. You know, it's really interesting to me because I feel like, you know, right now there's the one field to enter blood pressure, but as we look at these guidelines, we can see that the diagnosis and arc of treatment is so much more complex than just that one number. I mean, and especially if we bring in out of office readings. And I love that your registry, Dr. Still, includes places for home monitoring and for the 24-hour blood pressure readings, and then also your latest in-office blood pressure readings, so you can really manage that. So at this point, probably creating a registry is going to be the way we're going to have to go.
Absolutely.
Till things kind of catch up in the electronic health record world.
I wanted to ask if anyone's had a family member who may have been affected by these new guidelines and how that kind of is playing out for maybe a family member or friend of someone who's with us today.
Has anyone looked at these guidelines and gotten your mom or dad or yourself into the doctor and said, so my readings have always been a little bit high. What do you think about that? As my primary care provider, has anyone done that? Or have you taken extra special notice of, you know, you're in the pharmacy and you take your blood pressure and you say,
In my clinic, I think I would estimate that over the last month, probably 2 out of 3 patients have heard about the change in the lowering. They haven't been sure what to do with it.
There you go.
all right, do we want to switch to
Yeah,
home
so
monitoring?
thank you all for your thoughtful input. Thanks, Elisa, for the question. You know, when you registered for this event, we asked you what you hope to get out of the call, and a lot of people wrote that they wanted to learn a little bit more about the guidelines and understand them a little better. But people also wrote that they were interested in patient materials and, you know, maybe kind of how to some of this stuff. And if you were on the December call, actually, if you were on the December call, maybe just type in yes into the chat. Then we'll have an idea of how many of you were on that call. But we had 2 clinics in Utah who have implemented home blood pressure monitoring programs. And so they are a great resource for us. I'm just going to advance here a little bit and just so we have the bio slides so you can remember who they were if you were on, or if they're new to you. Catherine, if you want to intro them a little bit.
Is Carrie with us yet? Carrie, can you unmute yourself? Or
Oh, there she is.
Yes, I am here.
She's here. Okay, perfect. So Carrie was our presenter last month, and she's from the Ogden Clinic System. She is their quality manager, and she is an RN with 15 years of experience. Did a great presentation last month about their home monitoring program there in Ogden Clinic. And our next presenter was Jamie Fitzgerald. Jamie, are you with us?
I am.
She is. Thank you for joining us. So Jamie Fitzgerald is the nurse care coordinator for Access Clinics. She's also an RN. She's from Australia with that great accent. And she also presented and did a great job talking about Exodus's home blood pressure monitoring programs. So we want to open it up to some of the questions that you guys had last time about some of the specifics about those monitoring programs. Let's start off with talking about different cuffs. So I know I did a project like this, and we found out that the regular cuff was kind of small. I don't know who this regular cuff was for, but we ended up having to order large cuffs for all of our machines. What kind of cuff likes, dislikes did you guys run into with your programs?
This is Carrie. We actually used the Omron 10 series, and we did find that that was the same concern that we had. The cuff was rather small, and so we did purchase some larger cuffs that fit, but those compatibility, there weren't a lot that were compatible, so that was definitely a problem for us as well. One of the benefits of the Omron 10 series, though, that we felt was great was the fact that it would save the values and that it would also was battery powered or could be plugged in either way.
Oh, I like that I had the option for battery or being plugged in. That's really good. Jamie, did you
May
have
I ask one more question?
Yeah.
Oh, I'm so sorry. On the home blood pressure monitoring, I've just heard yes and no to this question. I just was hoping to get a final answer on whether or not a home blood pressure that's taken at home by a patient is an acceptable blood pressure to enter to your EMR as a measurement to treat hypertension or diagnose it.
So we considered at the University of Utah, we have a formal home blood pressure training program in our primary care clinics. And we work very diligently with the patients to try to get them to do it accurately according to the guidelines. And if we think that that is happening, then we do record that blood pressure in our EMR, and we measure that if that's below 135/85, at least according to the older guidelines, we consider that controlled. Now, right now, HEDIS and Medicare and all the other groups aren't looking at any of those things, but we think that's going to change soon.
Does that answer your question?
It does. Thank you very much.
Okay, perfect. Thank you for asking it. So our participants, it looks like not many of you were on the call last month, so we've got a new audience. We're interested to know from you, do you want to hear more about the home monitoring programs that we talked about last time, since you didn't get to hear about them? Or would you rather we go through some of the details of the home monitoring program that came up last time? So you got those two options.
Go ahead and chat in your answer for that. If you know, we don't want to assume that you we can have the clinics give a little highlight of their home monitoring programs, or if you have specific questions around those types of questions, that would be great. So maybe Carrie and Jamie, if you can be thinking for a minute while we're maybe getting some answers in chat, if you have some highlights. I know we only have a little under 10 minutes left, but maybe you could kind of hit some of the highlights. I know some people wrote in that they were interested in ways to better educate their patients or some of those skills. So maybe a little bit of focus on that. If you had ways that you felt like was successful, that you did that in your programs, maybe a focus on that would be helpful for people.
We have a couple people who would like information on both questions.
Okay. Okay, then why don't we let Carrie give you just a couple of minutes to hit some highlights of your program, and then Jamie will have you go after that, and then please send some questions into the chat based on what you hear.
Certainly, thanks for the opportunity. So we sat down and we came up with a process where these patients would be identified in the office with the elevated blood pressures, that either newly diagnosed or previously diagnosed that were poorly controlled. And at that process, if they presented with an abnormal blood pressure, then we would have the patient discuss with the RN means of being able to control that, going over lifestyle and what's normal, what's not normal. So they would provide some education, and they were also sent with a pamphlet that gave information on what's normal, when you should call your provider, and it gave them a log where they could list their blood pressure for a period of time. And then they would come back 1 week later and have another visit with the RN and review that log to see if it was consistently elevated versus if it was something that was a white coat hypertension situation. And then they would follow up again 1 month later with the patient's provider if it was warranted that they were truly hypertensive, and again 3 months later with the RN or provider, at which point, if they were in the normal range, they would graduate from the program. And we felt that the increased knowledge that the patient was able to gain and being able to self-monitor and be aware of what is normal and versus abnormal made a big difference in their ability to take ownership of the condition and make steps to improve those readings. Additionally, I should mention that we did have some blood pressure cuffs that we sent home at that time that they were identified in the clinic, and they were able to use those for a week while they were in the process of getting a new one for themselves, because that ultimately is the goal. We noticed that we had 2 different pilots, and there were 64% in one of the pilots who showed an improvement, and 55 in another who showed an improvement in those blood pressure readings from the first appointment to the follow-up appointment.
Great, thank you. Jamie?
Hi, thanks. So our program's a smaller scale, but we currently do have 40 blood pressure monitor cuffs in our clinic. There's a couple of ways we go about sending patients home with our monitors. One is they meet one-on-one with me for education, and then we do self-management with those patients. We send them home with materials. Once they've met with me and the blood pressure monitor, then while they're in office, we sign them up to visit with their PCP. We do 2 weeks currently with the device before they come back in, unless otherwise discussed with their providers. Secondly, I do training with our medical assistants. So when I'm not in the office, we can capture those patients if they don't get set up for a one-on-one education. And the MAs are shown the protocols we have in place within our clinic, and then they also send the patient home with a folder with the information on do's and don'ts of home monitoring, and then values. We have the values that they're to watch as well. We have 3 different types of home blood pressure monitors in our clinic. We have the Omron Series 10, which we love just because it has the self-seals for the patient, so it's very easy for them to use, especially if they're alone. Then we have extra large monitors, which comes through LifeSource. We just have 2 of those. And then we have the Welsh Allen, which you can buy different size cuffs with that monitor. Each of them are all AC adaptable and battery operated. And they also hold, they store the patient's measurements in there for us. But we also send the patient home with a log so they can see as well.
That's great. So I'm hearing the Omron 10 is one that both clinics have used. And have you been happy with that one?
I personally like it, again, just because the ease of use for our patients. And they're all pretty similar in prices. They're around the $100 mark once you buy a casing for the ones that we purchase. So we have more of the Omron 10s out of all of the monitors just because of the ease of use.
Okay.
We did have one question in chat. Are wrist BP cuffs appropriate for home BP monitoring?
Sounds like a question.
We have chosen not to use them.
Yeah.
Dr. Stoltz, do you want to weigh in on that? Using wrist.
So tell me what the question was again.
Using wrist instead of on the arm, the wrist.
Yeah, and so blood pressure increases progressively as you go from the aorta to the brachial artery to the radial artery. And so one of the concerns about the wrist cuffs is all of our studies are based on brachial artery blood pressure. So the guidelines currently do suggest that we don't use wrist cuffs. Now, that said, we see some obese patients who have cone-shaped arms, and you cannot get an accurate blood pressure with a standard oscillometric cuff, even extra large. And often you will get sky-high blood pressures. And so in those patients, that's when we do use the wrist cuff. We simply have to go with it and, you know, remember that it may be a tad higher than the brachial blood pressure.
Okay, does that answer your question? Or person that wrote it into the chat?
James.
Okay, thank you, James, perfect. Well, we are just about out of time.
We're putting some information in the chat for representatives, HealthInsight representatives that you can reach out to for all things. And then we'll be sending out a follow-up email after this call, probably in the next week to two. Once we get the recording finalized, then we'll email that out to you so you'll have access to that. Maybe Jamie and Carrie, I don't know if either of you have the chat available to you right now, but if you are open and willing to have people contact you with further questions, maybe you can add your contact info into the chat as well. If not, we can find it in a What final questions or comments do you have?
James Gibson wrote that yes, the question was answered for him. He thought it was great info and wonderful presentation and information.
Oh, thank you, Jeanette.
I'm curious, how many people are interested in doing a home blood pressure monitoring program at your clinic? If we have enough interest, that might be something
For a future topic,
right.
to delve into a little bit more. And thank you, Carrie and Jamie. You've put in your contact information in the chat, so you can access it there. Yeah, if you would like more information on this, just type yes in the chat and we'll consider putting something together in the future for another webinar offering. But thank you all so much for good. It looks like some people are working on it, so we're always happy to see that. And as you heard from Dr. Stoltz, with the new guidelines, there's going to be a bigger emphasis on home blood pressure monitoring. So tightening up those programs will be great. We've included a SurveyMonkey link in the chat as well. If you wouldn't mind taking that survey, we're going to email it out as well. But we really appreciate your feedback so we can make these more relevant for you and things that you want to hear about. So thanks for taking the time today to listen in and to contribute, and have a great rest of your day. Thank you.
Thank you.
Thanks, you guys.
Thank you.